In continuation with ECMO series, I am going to give a brief overview on different cannulation strategies in extracorporeal membrane oxygenation. We should remember that ECMO provides a physiological milieu for the recovery of heart in refractory cardiogenic shock. It is not a definitive treatment. It acts as a bridge until the recovery of the heart or transition to other mode of treatment. Coming to the basic principles of cannulation, the accurate and appropriate size cannulas with appropriate cannula position is a prerequisite for successful ECMO. We need at least 2 cannulas, one for drainage and one for return of blood. Additional cannula depends on individual case. Drainage cannula is usually placed in one of the major veins or the right atrium, and return cannula is placed in major artery or aorta in veno-arterial ECMO or internal jugular vein or the right atrium in veno-venous ECMO. We have different types of cannulas. Single lumen arterial cannulas are short and have single opening and are generally have one side hole. Venous cannulas have multiple openings and are of variable length, and they have both end holes and side holes. Wide wound cannulas are preferred to prevent kinking during ECMO run. Dual lumen veno-venous cannulas provide a simple means of providing a veno-venous support, and they have a bigger lumen for drainage and a smaller lumen for return. The returning port has a side hole which remains in the RA and directed towards the tricuspid wall. These are the different double lumen cannulas available in the market. So the Avalon cannula is the most commonly preferred dual lumen cannula, which has 2 drainage sites. One sits at the SVC-RA junction and the other in the IVC. The reinfusing port is in the right atrium and is directed towards the tricuspid wall. Smart cannulas are single lumen and self-expandable. The diameter is not limited by the diameter of the excess vessel. They provide superior drainage, and a pump or vacuum is not necessary for augmentation of venous return. According to the Poiseuille's law, resistance to the flow is directly proportional to the length of the vessel and the viscosity of the blood, and inversely proportional to the 4th power of the radius. Therefore, shortest and broadest cannula that is appropriate for a vessel should be selected. In adults, for veno-arterial cannulation, we can use either central access or the peripheral access. In central, we cannulate aorta and the right atrium, and which is the most common mode in patients who are fail to wean from the cardiopulmonary bypass, and in those who have significant hemodynamic instability in the perioperative period. In peripheral ECMO, femoral artery is cannulated for arterial access and femoral vein is for venous drainage. Right interjugular vein return cannula is placed when we need additional drainage. The different configurations used in peripheral ECMO are femoro-femoral, where we are going to cannulate femoral artery and femoral vein, or a high flow configuration wherein we use bifemoral cannulation with addition of right interjugular vein as an additional return cannula. In neonates, again, in veno-arterial cannulation, we can use central access or the peripheral access. In central access, as in adult, we use aorta and the right atrium, and the indications are the same as adults. In peripheral, we usually cannulate right common carotid artery for arterial access and right interjugular vein for the venous drainage. So, a brief on the neck cannulation in neonates. The head is turned on the opposite side of the cannulation, and a transverse incision is placed on the sternocleidomastoid midway between the chin and the manubrium sternum. The skin incision is deepened to get access to the sternocleidomastoid. It is either split or medially retracted to get access to the carotid vessels, and following heparinization, carotid artery and interjugular veins are cannulated. Those beyond neonatal period, again we can get access either centrally or peripherally. The central access and the indications remains the same as neonates, but in peripheral cannulation, either you can go through the neck by cannulating common carotid artery and right interjugular vein, or we can use groin. We can use groin in patients more than 2 years and more than 15 kgs, where we will cannulate femoral artery and femoral vein. Distal limb perfusion is an important aspect of ECMO run to prevent the distal limb ischemia. It can be prevented by cannulating the graft. A distal limb perfusion cannula can be placed, and more recently we are using retrograde perfusion via the posterior tibial artery. Left heart decompression is a vital role in patients with a severe ventricular dysfunction for the myocardial recovery. It can be achieved by open techniques, where we are going to cannulate right superior pulmonary vein or LA appendage or the LV apex, or by closed methods by using balloon atrial septostomy or transseptal perforation and placing a stent, or we can use additional drainage cannula through the septum, or we can do a limited thoracotomy and cannulate LV apex. Single ventricle patients represent a unique group in the pediatric population who requires ECMO support following various stages of palliation. Following first stage of palliation, the conventional occluding the stent during the ECMO run doesn't hold good now. Keeping the shunt patent and increasing the circuit flow gives the same efficacy as occluding the shunt. Glenn shunt represents a different difficult subset. They have a unique cardiopulmonary and cerebral physiology. So they have two separate sources of blood supply, one from the SVC, another from the IVC. Hence, dual cannula placement is must. So SVC should be cannulated to address the cerebral congestion before the femoral or atrial or SVC cannulation. Fontan group is another difficult subset. Transthoracic cannulation is difficult in this patient, and peripheral cannulation gives inadequate decompression. So they also need dual cannulae, femoral and interjugular. Veno-venous ECMO used for the respiratory support. So we can use different configurations. We can use femoral configuration, where we are going to cannulate both the femoral veins. In case of high flow configuration, along with the two femoral veins, we are going to cannulate right interjugular vein, or we can use femorojugular configuration, or we can use double lumen cannulation. In children less than 10 kg, VA ECMO is used for respiratory support because of the size constraint and the unavailability of smaller cannulas. Coming to the complications that could be cannulation related complications, such as vessel perforation, bleeding, dissection and distal limb perfusion. Recirculation is the complication very specific to veno-venous ECMO, where the infused blood is withdrawn through the drainage cannula without passing through the systemic circulation. The degree of recirculation determines the oxygenation efficacy of the ECMO. So this can be avoided by increasing the distance between two venous cannulae, use of double lumen venous cannula, or addition of another drainage cannula. Harlequin syndrome or North-South syndrome, which is very specific to veno-arterial ECMO. It is seen in patients with peripheral veno-arterial ECMO when the cardiac function recovers but the patient has significant pulmonary dysfunction. The deoxygenated blood ejected by the heart meets with the oxygenated blood from the ECMO circuit retrogradely at various interfaces, producing discoloration, bluish discoloration of the head and neck areas. This can be treated by converting to a central ECMO, either by cannulating aorta or the right subclavian artery, or converting to VAV ECMO, where an additional infusion cannula delivering the oxygenated blood is introduced into the right interjugular vein. Thank you.